now have the pleasure of inviting Dr. Hanumant K. Reddy. He is a senior consultant cardiologist at the Cardiovascular Institute of Southern Missouri from United States of America. Dr. Reddy joins us this morning to speak on the prediction of mortality and morbidity in congestive heart failure patients.
Thank you very much, Mr. Chairman. I thank Dr. Chopra, Dr. Nanda, Dr. Parashar, Dr. Rakesh Gupta, Dr. Satish Gupta, and all the organizers and my friends for inviting me to share some of the facts about mortality, morbidity, and heart failure in the next 15 minutes. And basically, it's always a pleasure to be here and to share these views with you. And thank you very much. And proceeding on. You know, my topic is discuss the predictability of mortality and morbidity in heart failure patients, which is a daunting task. In 15 minutes, it's very hard to cover, but I will just give you some salient points. As you know, every year, if not every day, we have to wager our salvation on some prophecy based upon imperfect knowledge. This is Mac Allais said that, and you cannot prevent what you cannot predict. So we have to predict something. May not be perfect, but we have to predict. If you don't predict, you cannot prevent. My predecessor already nicely emphasized the high morbidity and mortality of CHF patients. In spite of significant progress in the management of congestive heart failure patients, these patients remain at high risk for morbidity and mortality, and in fact, it is like a cancer. Some cancers are better than congestive heart failure. Congestive heart failure, is, as you know, is end-stage heart disease. So this figure already been presented before. In the United States alone, annual incidence of heart failure patients are close to 500,000, and prevalence of heart failure, 5 million people, annual mortality more than 250,000. And of course, heart failure is a very common cause of hospitalizations in the United States, and accounts at least 5% of healthcare costs. This condition affects 2% of the population, and as age advances, 6% of the population above the age of 65 have heart failure. And as we age, more and more people age in the United States and the world over, prevalence of heart failure is expected to be on the rise. So we have to look out for heart failure patients, more heart failure patients, and be aggressive with the management. So as you know, heart failure leads the list of causes of death in the United States. As you can see, right here, okay, sorry. But anyway, as you can see here, the sudden death accounts for most of the deaths in the United States, and all other cancers have to be combined to equal the number of sudden cardiac deaths with the heart failure. But now, what types of risks? There are many ways of classifying risk in heart failure. The two types of main risks are frequent and increasing severe congestive heart failure exacerbation. You know, heart failure itself gets worse. Patient gets admitted to the hospital for diuretics and other measures. And also the other kind is sudden cardiac death. Sudden cardiac death is terrible. It's a disaster. And of course, the factors associated with increased morbidity and mortality include age. As you get older, heart failure is bad for you. And disease progression, as disease progresses, whatever it is, coronary artery disease, valvular heart disease, congenital heart disease, cardiomyopathy, whatever it may be, as disease progresses, the heart failure gets worse. And frequency of hospitalization. After every hospitalization of a patient, there's a 30% chance of re-hospitalization within 6 months. So it is a bad thing. So once you're hospitalized, that indicates that your heart failure is already at a bad stage. So because of this high risk, physicians are obligated to pursue some kind of risk prediction. It may not be perfect, but we have to risk stratify these patients to see which patients are more likely to come back again or need therapy. And also, the most important problem with the heart failure patients is most of the physicians, even in the United States, don't make a diagnosis of cause of heart failure. Heart failure is not a diagnosis by itself. It's a symptom of a disease or diseases, multiple diseases, and also comorbid factors. So we have to find the cause of heart failure anywhere in the world, because if you find the cause, if you correct the cause, heart failure is cured or better. So that's a big problem. And also, you have to know which patients need which drugs. So some patients might need so-called second-line therapy, such as aldosterone antagonists, resynchronization therapy, left ventricular assist devices, which are going to be portable. I think India is manufacturing a couple of them. And then with cordless power. Now, HeartMate is going to be totally implantable in a few years. And also cardiac transplantation. Which patients need cardiac transplantation, which is not the best option? That's the last option. So we talked about potentially correctable etiological factors on heart failure. So every patient with heart failure needs the diagnosis of the cause of heart failure, pathophysiology. Now, hypertrophic myocardium due to coronary artery disease is the most common condition which is missed or ignored or neglected by our clinicians. So this has to be diagnosed. And my predecessor, Dr. Jain, already pointed out ischemia and heart failure, bad combination. If you have ischemia in heart failure patient, that has to be corrected, be either by mechanical catheter-based therapy interventions or surgery or whatever. And also the other important diagnoses which are missed are aortic stenosis and mitral stenosis. Mitral stenosis is not very common in the United States and other countries, but aortic stenosis, so-called occult aortic stenosis, and also sometimes, not very common, congenital heart diseases are missed in heart failure patients. Even in older patients, they can be missed. And a simple thing like that. Now, there have not been a good, perfect risk factor modification, risk factor prediction models. But within the last decade, the two clinical studies tried to do this based on real-world patients who are on real-world medications. So one of them, I just want to go over very briefly, study by Pocock and Associates. They used multivariable Cox regression models developed using baseline patient variables in a large cohort of CHARM patients, CHARM study patients. The CHARM study patients included both patients with systolic heart failure and diastolic heart failure. And the most powerful predictors in this model was age. The model predicted a 46% increase in hazard for every 10 years of age above the age of 60. So, and also the second most powerful predictor in this model was for left ventricular ejection fraction as expected. For every 5% decrease in ejection fraction below the level of 45%, there is a 30% increase in hazard. And also, of course, as you expected again, diabetes mellitus in non-insulin dependent diabetic mellitus patients, they have a 58% increase in hazard compared to the non-diabetics. And insulin-dependent diabetic patients have doubling of the risk. So other independent risk factors, which were independent risk factors in heart failure in this model, was higher New York Heart Association class, no surprise, prior hospitalization for congestive heart failure, and lower body mass index below 27.5, lower diastolic pressure in this patient, male sex, cardiomegaly, of course, previous myocardial infarction, and crackles in the lungs, pulmonary edema, atrial fibrillation, again my predecessor pointed out, mitral regurgitation, and orthopnea, rest dyspnea. So this actually lists the on the risk factor risk scores, normal distribution of risk scores, and relation of these risk scores to hospitalization due to heart failure and death on the top curve, and also the relation of the score to the probability of a patient having cardiovascular event within 2 years. The higher the risk score, the higher the probability of patient getting hospitalized or dying. And similarly, if you take a total mortality, the higher the risk score, the higher the chance of total mortality. Again, it's no surprise. And this curve, this plot, tells you the individual power of each of the risk scores plotted by Kaplan-Meier curves. As you can see, the probability of death and hospitalization increases as your risk score increases. So similarly, total mortality increases as the risk score increases in this small group of patients. So another study, so-called HF Action Predictive Risk Score Model, they use Cox Proportional Hazards Model to analyze the relationship between baseline factors and primary composite endpoint of death or all-cause hospitalization, and secondary endpoint of all-cause death alone in a cohort of 2,331 patients enrolled in so-called HF Action study. Basically, this study compared randomized patients to exercise training plus usual care and patient on usual care without exercise training. So basically, this is a byproduct of that analysis. So in this so-called HF Action Predictive Risk Score Model, over a median follow-up of 2.5 years, remember these patients were randomized to either exercise training with usual care or usual care alone. 67% of the patients, either they died or they were hospitalized within 2.5 years, and 17% died. The important prognostic factors in this model, as you might imagine, your grandma would have told you, Shorter exercise duration, the shorter the patient, are you able to walk maybe half a block or 1 block, 2 blocks? You're not able to walk because of shortness of breath. Of course, you're likely to get hospitalized, and maybe death may be a factor too. And lower so-called peak oxygen consumption, which is the metabolic test, which is not available universally, but this has a lower power than lower power than shorter exercise duration. And also the third one, interestingly, as you might imagine, so-called Kansas City questionnaire, in the last 2 weeks, how did you feel in the last 2 weeks compared to the 6 months earlier, a few weeks earlier? Did you feel worse in the last 2 weeks? That question alone predicted whether the patient is going to be hospitalized or have a complication. And lower ejection fraction, again, not surprising. Higher BUN creatinine. There's a good relationship with heart failure and the renal function. The better good renal function predicts good prognosis. This is an independent risk factor. As a matter of fact, bad renal function in combination with heart failure predicts high risk. So we have to watch out for these patients. Similarly, as you know, conduction defects, they predict higher risk. And severe mitral regurgitation with congestive heart failure, lower diastolic pressure, lower BMI, male sex. And of course, the other aspect of heart failure we talked about is sudden death. Close to half the patients, in all these multiple studies, half the patients usually die suddenly, of course. We have a cure for that. And then, as you know, mortality in New York Heart Association class 2 is 5 to 15%, and up to 80% of deaths are sudden in this group. And class 3 patients, mortality is up to 50%, and up to 50% of these deaths are sudden deaths. And class 4 patients, the mortality is up to 70%. They die more of heart failure rather than sudden death. So, and in these patients, one of the factors that predicts sudden death in heart failure patients is QRS duration. It's an independent predictor of mortality, more than 140 milliseconds, and the other factors we talked about. One last point I want to make in these patients is too often we put ICDs in patients to prevent sudden death. But just want to tell you, are we right ventricular apex pacing? If you make it obligatory or make it a parameter in ICD patients, that is harmful in patients with LV dysfunction because it causes so-called paced LBBB. So paced LBBB. So that causes abnormal LV activation and reduced stroke volume. And in fact, one of the complications of MADI-2 study, as you might be aware, the new or worsening heart failure was due to right ventricular pacing, causing ventricular desynchrony and worsening heart failure. So for these patients who are on ICD, intrinsic ventricular activation is better for ICD patients than RV pacing. And of course, as you all know, at least it states, 10% of the ICD patients have a class 1 indication for pacing, so they don't need pacemaker. They only need prophylactic ICD. So they do not need pacing. Basically, these patients have to be programmed so that they don't pace any time, only on demand. And in fact, the other study, David, so-called dual-chamber VVI implantable defibrillator trial in 2002, in those patients who had a ICD indication and they had a dual-chamber rate-responsive pacing, as you can see the top line here, there was increased incidence of hospitalization and heart failure in these patients compared to the patients with VVI pacing rate less than 40. So in summary, heart failure is like cancer. It's an end-stage heart disease, much like cancer. Therefore, hard work, diligent pathophysiological workup to make a diagnosis and providing appropriate treatment is extremely important. And in order to tailor workup for each individual patient needs to be risk stratified, and his or her risk needs to be emphasized, and so that you can tailor your treatment and be aggressive appropriately. And thank you very much for everything, for your attention.
Probably take up the questions for the next 5 minutes or so on the first 2 lectures with the chairperson's comments. Over to you, chairpersons. Ladies and gentlemen, the microphones are here in front of you. Please briefly introduce yourself and pose the questions to the chairperson and speakers. Thank you. Over to the chairpersons. Thank you.
Dr. Jain, you have mentioned this estimation of BNP in this congestive failure. Since the audience is quite mixed one, please give just clarify. This is a costly test as to when should we exactly do it, in which case we can omit, when there is a clear-cut clinical evidence of congestive failure, is there a need of doing it?
Yeah, thank you very much. The the most important place of BNP testing is in the emergency room when the patient comes to you with acute dyspnea. As I mentioned in one of the slides, that it may be a dilemma whether it is respiratory or cardiac. So that's the number one and most important indication of BNP. You know, practically speaking, the echo may not be available immediately. Even the simple X-ray test may not be available immediately. So BNP is such a simple bedside test that it can differentiate whether you are dealing with a cardiac or a non-cardiac dyspnea. So that's number one. Secondly, for prognostication also, it may be of some help.
Well, I think the comment about BNP is a good one. We did a study many years ago, about 7, 8 years ago, showed that BNP absolutely had no role whatsoever in people who had established diagnosis of congestive heart failure. And I don't think Hanumant was saying that you should do BNP in all, but I think your clarification is very worthwhile. Same thing applies for echo. A lot of money is being wasted by repeating echoes in people who come with decompensated heart failure, not just here, but also in the US. We have made a policy that if any fellows or anybody orders an echo, they better have a reason, otherwise they may be charged a penalty, because I think this is being most abused test that I know of BNP and echo in heart failure. Anyway, my comment is about the role of AICD and resynchronization therapy, because I have many friends and relatives in India, and quite often, injudiciously, these very expensive devices are being recommended for the patient, telling them that without that they cannot live. That is total nonsense, absolutely no rationale. People put their entire life saving, and the absolute reduction is minimal. And particularly it is done in Indian scenario without optimizing their medical therapy. And clearly, if you look at even the trials that are the best ones done in US and elsewhere, in those trials even the optimal therapy is not always at the maximum tolerated doses. So it's very important. For example, if you look at the magnitude of benefit with beta blocker, it's far greater than the magnitude of benefit that one gets with AICD. So I just want the people in the audience to know that one should take to heart these things and not drain the entire life saving of these poor patients.
I think it's a very, very important point Dr. Dedwani has raised. We should not abuse the technology. We should not abuse the test. The way he mentioned that, I remember a conference which I attended with Dr. Parasha in Baltimore, and there was a complete talk on BNP echo in every patient of heart failure. But over a period of time, we say we must define when to do BNP. Should we do BNP and titrate with diuretics? Should we do BNP and titrate with inotropes? When should we do it? Is it a diagnostic test, prognostic test, or does it help us in therapeutics? I think everything should be known and meticulously measured, evaluated, and then advised to the patient and not be misused. Second point, I think Dedwani has brought very, very valid. And the point is, no abuse of the devices unnecessarily. Please use effective dose of beta blockers. We don't use the effective dose of beta blockers, and patient or the guy is all the time in a refractory heart failure. Sometimes we are not able to define, is he in a combined failure, both diastolic and systolic, which is the dominant failure. Everything has to be meticulously defined, measure the filling pressures, and evaluate with the therapeutic intervention optimally before we think of device. Device also has an abuse. I think it's very well taken. Manjuran, want to say something? Yes, Manjuran.
I would feel that in the Indian scenario, I have slightly different opinion from what Dr. Dedwani has expressed. Echocardiography is a very simple investigation. Compared to what is the charges in the United States, it's extremely cheap. It's highly informative. Many patients with heart failure may have myocardial hibernation, and this we can study only if we do a serial echo. The diastolic, systolic heart failure can be clearly differentiated by doing an echo. Echo is really cheap, and I think this should be used as frequently as possible to improve the treatment as well as to prognosticate how these patients are doing. In America, it is $1,500 to $2,000, while in India, it is only just 700 to 800 rupees. Makes a big difference.
Thank you very much. I think Manjuran, you made his point.
Actually,
Depending on the cost effectiveness, Dr.
what
Parashar.
he meant was a repeat echo, but even according to the American College of Cardiology, echo is one of the first and the most important investigation in any case of a heart failure. But I think Professor Dedwania was talking more of a repeat rather than repeatedly repeating it or so.
Yeah, Ajay, you want to say something before we have another remark from Dr. Vijay Raghavan? Ajay Sinha? Ajay.
2 points. I am Ajay from Patna. 2 points I wanted to make out. One is that myocarditis is a very common phenomenon in our society. We keep on seeing children with myocarditis, and many of them go to situation like dilated cardiomyopathy, CHF. So this is one point you must keep in mind. Secondly, there are many causes of reversible cardiomyopathies, reversible LV dysfunction, of which calcium measurement for parathyroid disorders would be done. And B, many a times because of tachycardia in children, so-called tachycardiomyopathy is reversible. We keep on seeing those.
I think the caution that is given about the devices is very important. Many people forget the fact that for the indication of devices, there is a proviso that likelihood of living for more than 1 year is a must in the indication with the best medical therapy. Unless these two are possible, why should you waste the resources of a patient and the family? Number one, the best medical therapy should be given to the patient. Number two, the physician should be able to say there is definite likelihood of this patient living for more than 1 year before making them spend so much of money.
I think the comments by all the learned people are really fantastic, and I think the message is very clear. We have to individualize our patients. We cannot make a general policy. As Ajay was mentioning, there are patients who come to us with a catecholamine cardiomyopathy who needs a serial echoes. We cannot say, I did one echo and I will do after 10 days. It's not there. Similarly, he mentioned about the myocarditis. I think there are some subset of patients where we have to do more often echoes. As Dr. Parashar was mentioning, that one echo is very important. Subsequent serial echoes should be individualized. And as Vijay Raghavan has mentioned very characteristically and categorically, that there is no doubt we must balance the cost effectiveness. At which patient will be benefited more by medication, at least a effective medication for a year. And that's the way I think we can help our patients. Any chairperson want to say any comment before we...
First of all, you'll find that amongst the causes of heart failure, still in our country, I think rheumatic heart disease tops the list, which has not been mentioned. And it has been mentioned that we don't know what is the percentage of the rheumatic heart disease failure in patient. Second thing is, apart from the judicious use of drugs, and at times when you are needed the various devices, lifestyle modification is also equally important. Looking at the diet that a patient is receiving, looking at the fluid intake that the patient is receiving, and third thing, what drugs patient is receiving. There are so many times you find that patient doesn't disclose whatever drugs the patient is receiving. So many times you will find that cold remedies, which are commonly taken, is an important cause which will precipitate or aggravate the failure in a given patient. So I think these also should be looked for in a given patient, and every patient should have an individualized treatment. Thank you.
We would like to thank all the chairpersons and the speakers for an excellent interactive session on heart failure. We may take up the remaining lectures when the speakers arrive. So may now request Professor H.K. Chopra and Dr. Kalra to give the mementos and the certificates to the speakers.
Ladies and gentlemen, may now request first Professor Jain to please step forward and accept a memento from Dr. Chopra. May now invite Professor Reddy to kindly accept a memento. Thank you very much, ladies and gentlemen. That was session number 1 on heart failure.